Thank you for your patience as we begin today's Pulmonary Fibrosis Foundation Disease Education webinar series. Our topic today is the PFF Registry, current research, and new features. I am Junelle Speller, Vice President for the Pulmonary Fibrosis Foundation Registry, along with my panel members, Dr. Kevin Flaherty, Chair of the PFF Registry Steering Committee, Dr. Ayodeji Adegunsoye, Assistant Professor of Medicine with the Division of Pulmonary and Critical Care at the University of Chicago, and Ken Vella, Pulmonary Fibrosis Patient and PFF Support Group Leader. Welcome, everyone. But before we continue, I just want to touch on a few housekeeping items. We are being recorded. Handouts are available in the handout tab. And if you have any questions, please feel free to input them in the question link. We also want to thank our funders, Genentech and Boehringer Ingelheim, and other donors. A brief medical disclaimer, please note that any information contained in this presentation is for informational and/or educational purposes only. It is not intended to be a substitute for professional medical advice. Always consult your personal physician or healthcare provider you have regarding your specific condition. Next slide. Again, I'm Junelle Speller, VP for the PFF Registry. I've been with the foundation for about a year with previous experience in healthcare policy and management, and also experiencing running a suite of registries. Next slide. So first I want to start off with, what is a registry? We get that question a lot. The word registry is used for a variety of things, but in this setting, the official definition from the Agency for Healthcare Quality and Research is a registry is an organized system that uses observational study methods to collect uniform data to evaluate specified outcomes for a population defined by a particular disease, condition, or exposure, and serves one or more predetermined scientific, clinical, or policy purposes. Now that's a mouthful. I can't even get it out right. But in essence, simply a registry, next slide. Next slide. A registry collects and tracks information about the health status of patients and the care they receive. Next slide. A registry is used to describe the natural history of disease, examines factors that can influence prognosis and quality of life, describes care patterns, determines clinical and/or effectiveness of various treatments, drugs, medical devices, evaluates safety and harm, and ultimately is used to measure and improve quality of care. Now I want to pause here and just say briefly, a registry is different from a clinical trial. In a registry, a patient goes in for their usual ongoing care. That information is uploaded in their medical chart, and then on the back end, data is abstracted from your chart and inputted into the registry database. No additional visits are required, no additional treatments or drugs. We are just assessing the natural pattern of your care. Next slide. Just quickly, the benefits of registries. They collect the data in a natural manner, as I mentioned. We can collect data from a lot of different patients across the country, in different regions, in different care settings, community and rural. And it can reveal significant patterns or trends in the disease course, response to drugs, and more. Next. Next, please. It can also measure and improve the quality of care, and it does not require an individual to follow additional treatment, take any more medicines, or get additional medical care. Next slide. So with that, we go into the PFF registry. And our tagline, we believe it's patient-powered, data-driven, and research results. Next slide. So the PFF registry started some years ago. Many of you are familiar with the registry. It was focused in the care centers across the country. There were two components to it. It was a larger component for clinical data to be uploaded. This was reported through your medical chart and uploaded by a data coordinator and put into the registry database. The data included information on your diagnosis, labs, tests, treatments, and various medical events. We gathered data for about 2,000 patients, and of those 2,000 patients, 80% elected to participate in the biorepository. The biorepository included a single sample of blood at enrollment, and then an HRCT scan at enrollment and as clinically indicated. These patients were followed from that time. Every 6 months, there was follow-up and data was uploaded. Next slide, please. I mentioned earlier that data is actually currently collected in 42 care centers, and I slipped and said was because as we move into the changes upcoming, you'll see the expansion. So the various types of data collected include clinical data, medications, labs, and other test results, and also the addition of COVID. So whether you were diagnosed with COVID, vaccination, how your care went, and so forth. We also have the biorepository, which I touched on briefly, that includes a blood sample comprised of DNA, RNA, serum, and plasma. The HRCT images, medical events like lung transplant, hospitalization, and then the patient-reported responses to a set of 4 short questionnaires that are administered and completed by the patient at enrollment and every 6 months. So key metrics include information on patient demographics. So we're finding that the mean age of participants is about 68 years old. The majority are men, and about 40% are on antifibrotic treatments. You see here in this slide the mix of race and ethnicity, and then the age at enrollment, the age range here at the bottom. Next slide. So we have a fairly comprehensive mix of diagnosis groups. And I just want to add in that first phase of the registry, we were committed to getting about 60% IPF patients. We did indeed get those patients, 62% actually as of our current, along with other diseases, including hypersensitivity pneumonitis, occupational exposure, and autoimmune disease. Next slide. Currently, patients average about 47 months in the registry, with 80%, a little over 80%, donating a blood sample, and almost 90% agreeing to future research. So when I say future research here, what we try to do is link those patients to existing clinical trials. So in the short time that we've been in existence, we've accomplished a lot. You see this timeline here, where we had our first patient in March 2016, our last patient in June 2018, and we've produced a lot of research within that time. So as we look ahead, next slide, we are looking to expand our reach. Now, currently, I mentioned we are in the care center, and just because you're being seen in a care center doesn't necessarily mean you are in the registry. There is an enrollment process that's required to be part of the registry. And so what we're finding is there's limitations in the data and just looking at 2,000 patients within the care center. In the next step, we want to expand outside of the care center, continue the care center work, but go outside of the care center and gather information on patients in various settings, and then also patients who've received a lung transplant, caregivers, and family members. We really want to look at the true impact of pulmonary fibrosis. Next slide. Next slide. So with that said, you can see we'll continue to expand our reach across the United States. Next slide. So in the next phase of the registry, we'll continue the care center, and then we'll add on, next slide, the community registry. So the community registry, we're very excited about this. We will offer an annual questionnaire to all patients, family members, and caregivers to provide self-reported data on your demographics and basic medical history and lifestyle. This will be a no cap, as many people as possible would participate in this. And then as we continue, we would have a percentage of those participants participate in quarterly or biannual surveys on key topics like risk exposure, treatment, and other issues. A segment of those will continue in the Care Center registry. Next slide. So I've shared a lot with you today. Certainly, if you have any questions, you can reach out to me at registry@pulmonaryfibrosis.org. And then you can also sign up to hear more about the registry and to enroll once we launch later this summer in June by signing up at this link. This link will also be provided in your handout packet, but we are really excited about this opportunity ahead and the opportunities to glean further research and improve the care of people with pulmonary fibrosis. Next slide. So with that, I will hand off to my colleague, Dr. Kevin Flaherty. A brief introduction of Dr. Flaherty. Dr. Flaherty is the chair of the PFF Registry Steering Committee, and he's also at the University of Michigan Health System. He is the director of the University of Michigan Medicine Interstitial Lung Disease Program, vice chair of the Medical School IRB for Human Subjects, associate program director, Internal Medicine Residency Program, and co-director of the University of Michigan Medical School Scientific Discovery Pathway. Dr. Flaherty is very, very busy, so we're really excited to have him on board today. Dr. Flaherty, I'm going to hand it off to you.
Awesome, great presentation, Junelle. And again, I want to extend my welcome to everyone. It's exciting to be here. What I'm going to do over the next 10 minutes or so is talk about 3 of the rather larger collaborative projects that the registry is involved in, as well as to give a little bit of an instruction just very briefly about how you could potentially use the registry to do research as well for the data in the registry. So next slide. These are my disclosures. Next slide. So I wanted to start with a historical perspective and very briefly show how that got us where we are and where we're going today. If you go back 20 years, the standard of care to treat idiopathic pulmonary fibrosis was immunosuppressive therapy. Almost everyone we were treating was being treated with medicines like prednisone and azathioprine, although there had never been a randomized clinical trial, as Junelle mentioned, to study and prove the safety or even efficacy of that approach. It was just a thought, with good science behind it perhaps at the time, that inflammation must drive fibrosis, so we must use immunosuppressive therapy, and that's what we did. Now, around this time of this study, in the early 2000s, there was data emerging that the redox capacity of the lungs, the antioxidant capacity, was low. And so there was interest in looking at an antioxidant called N-acetylcysteine. And the study you see on your screen was a randomized controlled trial done in Europe, where everybody in the study got the standard immunosuppression that everyone was getting, azathioprine and prednisone. And then they were randomized, like a coin flip, to either get the antioxidant N-acetylcysteine or placebo. And what these 4 graphs show are just different representations of lung function. And the take-home point was, if you got immunosuppressive therapy with the antioxidant N-acetylcysteine, compared to the immunosuppressive therapy alone, your decline in lung function was slowed down. That was very exciting. This was a positive trial. It's published in the New England Journal of Medicine, and there were strong arguments that this should become the standard of care. However, there was also some concern, scientific concern, that this wasn't the best study because no one ever looked at that immunosuppressive therapy, and there was no true placebo. So on the next slide, in collaboration with the National Institutes of Health, they funded a network study across the country called the IPF Net. And what this study did was it pulled apart that last study. It randomized subjects that were willing to be in the study to placebo, N-acetylcysteine alone, or what was the winning combination in the prior slide, this immunosuppression with prednisone, azathioprine, and N-acetylcysteine. We didn't know which one of these was going to work, if any of them. We had hoped that perhaps N-acetylcysteine would work by itself because it's inexpensive and seems safe. On the next slide are the first results that came out of the study, and we were shell-shocked. It turned out that that winning combination in the New England Journal of Medicine article, the azathioprine prednisone with N-acetylcysteine, when it was compared to a true placebo, not only did it not work, it was harmful. It resulted in increased mortality, increased hospitalizations, and absolutely no benefit. It completely changed our philosophy and landscape around the treatment of IPF, moving away from immunosuppressive therapy. Now, you may be thinking, well, what about that N-acetylcysteine arm, that middle arm of it by itself? On the next slide, so the study continued with that NAC arm, N-acetylcysteine, compared to placebo alone. And if you look at the outcomes of those two curves, it looks like the change in lung function was the same between both of those. So we were very disappointed. We said, well, it wasn't harmful, but it didn't help. Darn it. However, an important part of this study is a large number of people that were in the study put their arm out, just like people in our registry do, and say, take some of my blood and you can use it for research. And on the next slide, we went back through the data. We looked at blood samples from people that were in the study, and we looked at one of the genes that has a relationship with IPF, an immunoregulatory gene called TALP. And there's three common genotypes or polymorphisms, just the way the gene is expressed in that TALP gene. And when we stratified that NAC response by those genotypes, on the far left, about 25% of the people, it looked like they were actually harmed by N-acetylcysteine. The 50% of the people in the middle genotype, it didn't have any effect. But the 25% of people on the right, 1 in 4 patients with the TT genotype in the study, looked like NAC may actually be beneficial. Wow, there's a lot of interest now, right? Maybe we should study this genotype. But you can imagine trying to do a clinical trial where, by definition, 3 out of every 4, 1 on the left, 2 in the middle, those 3, 4 that don't have the right genotype would be a screen fail. That's very, very difficult to try to do a study with that many screen fails. But there was still a lot of interest in doing this pharmacogenomic study. And so on the next slide, that led to what the first major collaboration I want to tell you about is the precision study. So as Junelle mentioned, the registry has been going on for a while. We enrolled 2,000 subjects. The majority of people were able to give a blood sample. So we had in our biorepository blood samples of hundreds and hundreds of people with pulmonary fibrosis that we could, at the ready, do the genotype and then contact subjects that were willing to be contacted about potentially participating in the study, and only contact those that might have been eligible. And so that's what this precision study is. It's a huge grant, $22 million. It's a combination of the government, the National Heart, Lung, and Blood Institute of the NIH, as well as Three Lakes Foundation. And it's going to do 3 different things. On the next slide. So it's going to do that pharmacogenomic clinical trial. It's going to do a placebo-controlled trial of N-acetylcysteine in the subjects that have the potentially beneficial genotype. They're also going to do a lot of blood transcriptomics, proteomics, looking to see if blood samples from IPF and other non-IPF interstitial lung diseases can be distinguished on that, or if we can figure out risk factors for progression, prognosis, et cetera. So a very large collaborative grant that was made possible by the existence of biosamples within the registry and the Care Center network. A second collaboration I want to tell you about is on the next slide. And this is a prolific consortium. This is a consortium between foundations, between industry sponsors, where people are putting resources, both financial and intellectual, together, working as a team to do, next slide, a study to try to develop bioassays from blood markers that can help us predict the course of IPF, as well as learn other things about the disease. It would be incredibly helpful if we had a blood sample and we could do a test on it and say, you are at risk of progression, or actually your disease is quiet right now. Take a deep breath, relax, we'll check on you in the future. We don't have any way to predict the future right now, but part of the study is to try to figure out if we can develop prognostic and predictive biomarkers from blood samples of patients with fibrotic lung diseases. Next slide. So there's a lot of data in the registry. There's biospecimens in the registry. There's HRCT studies that have been uploaded. How can we use those? So if you click on the next link, the animation, you can go online and there's an application process. Basically, you fill out a very brief application about background on why you want to do this study, what is your study methods, If it requires funding, how are you paying for that study? That study is then reviewed by a scientific review committee. It's reviewed by statisticians to see if the analyses are doable and appropriate based on the registry data. Sometimes it gets feedback and tweaked, but eventually those data can be released, studied, and lead to publications to help us better understand fibrotic lung diseases. Next slide. And now it's my turn to pass the baton over to Ayodeji, who's the Assistant Professor of Medicine and the Scientific Director of the Interstitial Lung Disease Program, Section of Pulmonary and Critical Care, Department of Medicine, University of Chicago. He's an Assistant Professor of Medicine at the University of Chicago, a pulmonologist who specializes in interstitial lung diseases, genetics research, and healthcare disparities. I've seen that this is going to be an excellent presentation, and I can't wait to hear it. So, Ayodeji, the floor is all yours.
Thank you, Dr. Flaherty, for that kind and generous introduction. And thanks for inviting me to participate in this webinar. Over the next 10 minutes or so, I'll be highlighting some aspects that underscore the importance of the Pulmonary Fibrosis Registry to pulmonary fibrosis researchers like myself and around the world. Next slide, please. So these are my disclosures that you just saw. Now, you've heard a lot about the registry already from Junelle Speller and from Dr. Flaherty about work that's been accomplished already. But let's take a closer look at who's in the registry. Around the time the enrollment ended, there were about 2,000 participants, of which the majority were men, and almost half of them were over the age of 70 and predominantly white. Now, one of the fundamental goals of research is that the findings are reflective of the larger population. That's a concept that epidemiologists often refer to as external validity. And this principle is really of critical importance, and that's why very careful measures are often implemented to ensure this occurs when enrolling patients in clinical trials and other prospective studies. So simply put, representation matters. As you'll observe with the next click on this slide, while we are focused on pulmonary fibrosis in the adult population, would really like to see more enrollment of females and minorities with numbers that approach what we observe in the broader US population. And so with the registry now moving on to the next phase, as you've heard, it is of great importance that more patients from these demographics are enrolled for participation, because that would help us understand the disease that we're working on and develop new therapies that would work for everyone. As you can see from this slide here, to emphasize this point, I'll just reflect back briefly to a previous webinar that was presented some weeks ago that highlighted differences in pulmonary fibrosis by race. And the study you see on the right-hand side of your screen was performed almost 10 years ago. And it showed that Blacks with the idiopathic form of pulmonary fibrosis seem to die at a younger age. That was the data that they had to work with. But you'll agree with me that with 5% of the entire registry being Black, as I showed you on the previous slide, it will be challenging to fully understand all the reasons for this disparity, given the small numbers that we have to work with. And so we'd really love to have a more intentional focus on inclusion and diversity in the next phase of the Pulmonary Fibrosis Registry. Next slide, please. So, but these differences in race that I've just talked about also highlights the importance of homogeneity in recruitment of patients and how it also impacts gender as well. We'll observe from the slide on the screen that there is a 2-to-1 male to female ratio that is seen amongst whites in the registry, but that is reversed amongst the Black participants. So obviously this raises several questions. Are Blacks, for example, with pulmonary fibrosis more likely to be females? Or are Black female patients more likely to enroll in pulmonary fibrosis studies? Or are Black females who have pulmonary fibrosis more likely to have more severe disease and present with symptoms earlier? Now, all of these questions deserve further exploration to help us provide meaningful answers to these questions. Next slide, please. So, while the idiopathic form of pulmonary fibrosis was seen to be very common amongst white participants in the registry, when we evaluated these populations, the Black and the white populations, and stratified by pulmonary fibrosis subtype, we'll observe that there is a 4-fold increase in the prevalence of pulmonary fibrosis that was related to underlying autoimmunity. So we often call that the connective tissue disease-related interstitial lung diseases. Now, these are due to conditions like rheumatoid arthritis, scleroderma, lupus, myositis that involves our muscles, and several other autoimmune-related conditions. Now, these stark differences in the cause really underscores the need for greater diversity in the registry to help us better understand the reason for why do Blacks have a greater preponderance of these autoimmune related conditions as opposed to other racial groups. And that's really an important question to answer. Next slide, please. So thinking beyond IPF actually now, the idiopathic form of pulmonary fibrosis, to the broader umbrella of pulmonary fibrosis, we have often wondered if there are distinct differences in the age at diagnosis, because evidently this could impact the life expectancy of patients who are affected. So when we evaluated enrolled participants in the pulmonary fibrosis registry, we observed a 10-year difference in the age at diagnosis between patients that were Black on the one hand and those that identified as white, so self-identified as white participants. We independently assessed the ILD registry at 2 other centers, so in Chicago, the University of Chicago, and in California, the University of California, Davis and San Francisco, and we found almost identical results. So also, if Blacks are diagnosed earlier, do they have a shorter life expectancy? As you'll see on the next click from the panel at the bottom right hand of your screen, the data from the UChicago population I just showed you might suggest that this will be the case. And we're looking into this now on a nationwide scale. Are Blacks likely to have a younger age at death compared to other racial groups? Obviously, several socioeconomic factors and their health ramifications could account for this disparity, but this has great implications for how we manage the disease, especially when we think about the correlation with other diseases like colorectal cancer, where there's a huge disparity also in the age at onset of disease and the age at death as well. Next slide, please. More recent work that emanates from the registry revolves around identifying distinct clinical phenotypes with a similar pathobiology that can really help us more accurately target the underlying pathways that are involved in this disease, in the disease etiopathogenesis. In one of these studies where we worked closely with Elizabeth Freihardt from the SABER group at the University of Michigan, we relied on machine learning algorithms and advanced statistical techniques, and we observed that patients may more broadly be grouped into 4 categories based on their sex, smoking status, the age or time from disease diagnosis, and autoimmune or chronic comorbidities that they may have. Now, this is irrespective of the current terminologies that have been applied to their disease. As you can see from the right-hand side of your screen, patients within these clusters, as we call them, spanned all the categories of the ILD subtypes as we currently call them today. Next slide, please. What was great about this was that the lung function of patients within each of these clusters had a similar disease behavior over time, and they tended to be different or distinct from that of patients within other clusters. Even at 1 year after enrollment, we observed numerical differences in survival across these 4 clusters. And now that we have longer-term data since 2018, we're seeing even more statistically significant differences that may have an impact in the way we conceptualize about pulmonary fibrosis. Next slide, please. Finally, more and more clinically impactful research is being published as a result of the rich data within the registry. And this impacts how we think about the value or the limitations of blood thinners in patients with pulmonary fibrosis. So factors that impact the use of antifibrotics as well, which slow down the progression of pulmonary fibrosis, the value of quality of life metrics, which biomarkers have proven utility or are valuable in pulmonary fibrosis, and several other questions of importance to patients, caregivers, and healthcare providers. So there's a lot that has been done so far, but there's still much that remains to be accomplished as we navigate the process towards a cure for pulmonary fibrosis. Next slide, please. So finally, I'll be remiss not to acknowledge a lot of people that have been very instrumental in the studies I just showed you, including colleagues at the University of Chicago and funders of these research endeavors. But most importantly, I really want to give special thanks to the patients with pulmonary fibrosis and their families who make these studies possible and give us the opportunity to find innovative therapies. So I'll pass it on to Ken Vella at this point, and thank you so much for listening.
Well, thank you, Deji. So as just a kind of a brief introduction, I was diagnosed with IPF over 3 years ago. And fortunately, my pulmonary health has remained actually actually pretty stable. And I believe this is a result of the good medical care I've been receiving, of making some life changes, and immediately starting on one of the PF medications soon after I was diagnosed. And part of my good medical care, I believe, was enrollment in the PFF Registry, which started actually on the same day as my diagnosis. I was actually through the PFF Registry that I learned about the Pulmonary Fibrosis Foundation. So, you know, as I remember it, on that day after I met with the pulmonologist, a clinical coordinator on staff there asked me if I wanted to participate in the registry. And honestly, I was still very much processing my diagnosis. So I really didn't think too long about this choice, but I do recall thinking that just sounds like the right thing to do. Why not participate in the PFF registry? And you know, up to that time, I really had never participated in any clinical research. I really had no reason to even think about doing that. But since I participated in the PF registry, I've actually participated in 2 clinical studies. I just recently started a clinical study at the University of Michigan under Dr. Kevin Flaherty's direction. And you heard from the previous presenters how much of my information, my medical care is being collected in the registry. So I won't repeat all that, but essentially my entire PF medical plan has been captured for about 3.5 years now in the registry. And the way I see that is that all that data can be used by medical providers and medical researchers to better diagnose and treat pulmonary fibrosis. And I know from my previous background before I retired that the more data that we have, the more opportunities we have to find additional medications and ultimately a cure for this disease. And after all, isn't that what we all want? We want to find a cure for this disease. So I believe the expansion of the registry to include patient and caregiver direct access, well, that just makes sense. And it will further increase valuable information for medical providers and researchers. You know, for example, I think about all of the helpful information our support groups contribute each month. You know, things like tips like managing oxygen and managing the medication side effects, which as patients, you know, that can be a challenge. Or, you know, eating tips, what works best when you have pulmonary fibrosis, what doesn't work. Well, all of this information can be captured in the registry now. And caregivers will be able to contribute to the registry as well. And, you know, I think caregivers, well, they have perhaps a different view of pulmonary fibrosis than we do as patients, and that information could also be very useful. So the other advantage I see here is very simple. It's a very simple one in that we'll be able to access the registry from home, kind of on our time. We won't need to wait for our pulmonologist appointment or go to the clinic to update our medical plan and our observations directly into the registry. So those are my brief thoughts and comments, and it's my hope that all of you and the other the other patients and caregivers, once the registry opens up for direct access for all of us, that we will see the benefits of participating in the Pulmonary Fibrosis Foundation registry. And it'll only help all of us in our ultimate care of this disease. So with that, those are my thoughts, and I will turn it back over to you, Junelle, for the wrap up.
Thanks, Ken. I really appreciate you sharing your experience with the registry so far and really going on about the benefits in participation. And also thank you for pointing out how the registry data not only feeds into research, but also advocacy efforts for our patients, caregivers, and families. With the community registry, we want to not just get the data from you, but use that additional data to feed into those advocacy efforts, continue to feed into research, and then also to assess practice patterns and other things. So this will be a really robust and comprehensive strategy as we look ahead. So I want to invite our panel members to come back online, and we will take questions at this time. While we wait for questions, I want to initiate a few questions for our audience. So first, I'd like to know, are you participating in the current registry? I'll give a moment to answer, yes, no, you don't know, and some patients don't know, but it'd be great if you let us know. All right, okay, so I will, still waiting, looks like a few additional respondents are coming in. All right, so it looks like the majority of you are not in the registry. About 13% are and 17% don't know. So clearly we have some more work to do there. There is still that opportunity for the Care Center registry. The community registry, which will launch in June. And so I'll go on to the next question. Do you plan to join the PFF community registry when we launch in June? Okay. All right. And so it looks like the majority of you do plan, and we do appreciate it. Again, as Ken says, the more data we amass, the better picture, the better idea we can get of the true impact of pulmonary fibrosis. So it looks like we've gotten a question for our panel. I have been followed in the registry through my Care Center Network Care team to include blood, HRCT, and surveys. Will my participation continue through my current CCN participation, or do I need to register again when the new rollout occurs? So I'm going to hand it off to Kevin. Dr. Flaherty.
Great question.
Mm-hmm.
And the answer is basically yes, in terms of we'd love for you to join the community registry, as Junelle just said, which would be a separate process. And because the registry protocol at the centers will be a little bit different, the informed consent process will have to be updated. And so you'd have to re-sign a new informed consent document about the new protocol, just because this one will be a little bit different in terms of things that are collected in the partnership with the community registry. So the answer is yes, and when you're at the CCN site for your next appointment and future appointments, you could just ask your team there if things are ready for you to re-register, and we certainly hope that most people will be able to do that.
All right, wonderful. So it doesn't look like we have any additional questions coming in at this time. So I'll open it up to our panel members to make additional comments or ask questions of each other if you would like.
I'm mute here. Speaking from a patient perspective, yeah, sorry about that, a little slow on the draw. So just speaking from a patient perspective, I'm just thrilled to see that in this time of COVID that we can still come up with financial resources and smart people to continue to advance research and to lead the way in finding better medical therapies and hopefully ultimately a cure for this disease.
Yeah, thanks, Ken. It really is. It's a collaboration between physicians and investigators and patients like yourself, and especially with COVID, right? Because it's certainly, it's safer to be at home, and coming in to get a study visit done at a hospital that's full of COVID people is scary. With all the precautions that we try to take, it's still not as safe as staying at home. Appreciate the courage to even enter a study when we don't know if the medicine is going to be helpful or could potentially be harmful, like the data I showed. So it's very courageous to be in a study, both from taking on the study itself, but then also in COVID of coming to study centers. So it's greatly appreciated. So thank you.
You bet.
I'll just echo Dr. Flaherty's statement. Again, thank you so much for your contributions to the registry, to helping us better understand pulmonary fibrosis, particularly with COVID now. The data that has been accrued over the last several years presents us with a backdrop to understand pulmonary diseases in general. And as COVID continues to get a lot of studies that focus on that, we can compare how the long-term effects of that compared to what we have currently in the pulmonary fibrosis registry. So thank you again for your help.
Quite welcome.
Yeah, so there's another question here that asks, the community registry that Junelle talked about, how is that going to complement the more traditional registry at the centers? And there's lots of different ways that can happen. And I'll just touch on one or two perhaps. One is the ability to reach beyond the centers, to reach into the communities. Not everyone is able to make it to one of the Care Center Network sites. So to be able to look at data from families and caregivers and patients that are not necessarily at the site is going to be very exciting to see what that looks like, and I think we'll learn a lot. The other thing that we'll be able to do is reach out, as Junelle said, periodically with different surveys or questions. There's never a shortage of research questions, and they're evolving and coming up all the time. And being able to have an outreach to say, well, here's an area of interest, and here's a survey that we're going to try to dive down and to learn about that, and to not have to wait for people to come into a study center to take that survey, but be able to reach out broadly across the United States to ask that question and see what we learn will be important. So I think it's going to be really exciting to see how this evolves, and I honestly believe that the benefits, we think it's going to be great and very, very beneficial. There's a lot of enthusiasm around it. But I really think that what actually will happen will be even greater than what we imagine. I think it's going to be something that turns out to be very productive and very exciting. So thanks for that question.
All right, so Dr. Flaherty or Dr. Adegunsoye, we have another question here. So these data from the registry will also be shared across clinical trials. So they're asking if our data will feed in or affect any of the clinical trials that are out there.
Yeah, I'm sure Dr. Flaherty can provide additional insights into this, but what we've had historically before the conclusion of enrollment into the present iteration of the registry, what we often call Registry 1.0, most of the data was well curated, and a subset of those are actually very, very good data sets for enrollment of patients into clinical trials. So either for primary enrollment or for validation of what has been found in clinical trials. And so I think that as we move on to the next phase of the registry, there are channels that have been built in to make sure that the registry itself complements what we have from multi-center clinical trials around the country. And a subset of these patients actually do have dual enrollment, particularly at our center at the University of Chicago, in the PFF registry and in clinical trials as well. So enrollment in the registry does not necessarily preclude patients from enrolling in clinical trials. It often is complementary along the line. Dr. Flaherty?
No, I agree that I think the data are really complementary. The registry collects data that is part of the standard of care in as opposed to a clinical trial that is very protocolized. So it provides similar but yet complementary data. And as I mentioned with some of our, evolving collaborations, we may be able to use data from the registry to help inform the design of clinical trials as well. So I think they really are different beasts, looking at things in a different way, but all try to answer important questions.
All right, thank you. The next question here, do you track patients in the registry as to what antifibrotic medications they take and the effectiveness? Kevin?
Yeah, so we certainly do track medications that people in the registry are taking. We have to be, careful, realizing that this is not a clinical trial where people are assigned randomly to one or the other. So there are potential biases. People may not be on a medicine because of intolerance or things. So we track that information, but we have to look at it carefully to make sure that we don't overinterpret the data. But yes, that is something that we are very interested in and collect information on.
All right. And then we have another question here. How do I find out if I'm in the registry already?
I can speak from our local experience, and this is a question I hear oftentimes from patients when we tell them about the PFF registry. So again, with the current iteration of the registry, most of the patients that were enrolled came in through the channels of the PFF Care Center networks, where hospital centers where patients get their care, patients there are presented with the opportunity to get enrolled into the registry. And so it's imperative for individuals who want to find out if they were in the registry currently as it stands to go back to their primary site of enrollment. And at that time, they often would have signed a consent to get enrolled in the registry. I think those channels are the primary means by which patients get enrolled into the registry as it stands currently.
All right. So we have another question here. A participant's husband died, and she wants to know what her role is. Is there an opportunity for her to participate in the registry?
Yeah, so certainly could participate in the community registry when it's open as a caregiver, and I'm very sorry for your loss.
All right, so it looks like we're nearing the end of our time here. We want to be respectful of your time, even with our technical difficulties. Are there any other comments from our panelists before I close out?
No, thanks, Janelle, for running this, and for the organizers and for the sponsors to allow us to put this on, and for everyone that took time to listen to us today, took time out of your day. So again, we're trying to move forward together as a community to cure this disease. So every step helps. So thanks for everybody's support.
Absolutely. I'll echo the same thing as well. For our patients out there, thank you so much for contributing your data to this robust registry. Hopefully, we can make substantial progress over the next several months to years in finding a cure for this devastating disease. So thank you.
All right, and Ken?
Well, thanks, Junelle, for leading the charge and taking on this new responsibility at the PFF.
Thank you. And again, I want to thank the participants in the registry, those existing patients, and those who will sign up. We also want to thank our funders, Boehringer Ingelheim and Genentech. Again, handouts are available here in the link to your right, and then we'll also have that available to participants directly. Finally, we will provide a recording of the webinar today on a YouTube link, and thank you again for participating.
Thanks, everyone.
Bye-bye, everyone.